Hello, everyone. Hope you're having a great day. He is Paul Gerard. I am Kevin Kelly. We are Gerard and Associates. Please check us out at gerardassociates.com. You're listening to the GNA Way podcast, and we thank you for that. Paul, once again, great to be with you. We got another great topic.
Yeah, we do. Great to be with you as well. So I'm eager to talk about this one.
Yeah, so today, Paul and I are going to talk about the evolution of the technician level paramedic to the clinician level paramedic. As you can see, there's no more NREMT-P. They took the EMT out of the title and they made us NERPs, Nationally Registered Paramedics. They took the technician out. They took the T out. NERPs are clinicians. Nationally Registered Paramedics are clinicians with substantially more academic knowledge. And our nationally registered paramedics are pre-hospital diagnostic masterminds. They need to be used as such. Now, accordingly, much more is expected from nationally registered paramedics. The NRPs bring the emergency room to the patient's living room, or wherever. Could be in the car. They have the core competence and expertise to begin advanced level care at the patient's side. That's what they should be doing. No more scoop and screw, Paul. No more load and go. And certainly no more you call, we haul. Ambulances are not taxis. And just like Farmers Insurance, Paul, we know a thing or two because we've seen a thing or two. And with our over 18 years of coaching our BMS CQI with some 300,000 CQI coach 'em up sessions, we no doubt see opportunities to plug holes in the proverbial Swiss cheese. How do we do that? By beginning patient care at the patient's bedside. So, Paul, what are we seeing as patient care and provider risks by the old scoop and screw method of patient care?
Well, there's a significant amount of risk. Most jurisdictions that we work in have implemented, start treating patients at the patient's bedside protocols, whether that's informal or formally. Even agencies that don't have that in writing, we very often, when we send these calls to medical directors for review and say, hey, you should have stayed on scene and treated this patient, they'll agree with that. So they're very much in tune with it, even if it's not in writing in some form or fashion. And really, it's something that's evolved over the years, but it's been quite a few years now where, at least up here locally in the Northeast, where medical directors, state protocols, affiliate hospital medical directors have all started to encourage providers to treat on scene. And it's precisely for the reasons you mentioned. We now have the knowledge, skills, technical ability to do everything for that patient in most cases that the patient needs. And so doing a quick extrication, a scoop and screw kind of thing, can be detrimental to the patient. So in the process of extricating that patient, the patient has the chance to deteriorate, and then you're starting from a worse position. So the evolution of these policies has been toward bring all your equipment to the patient's side, start treating that patient immediately, and try to alleviate the condition for which you're there to treat the patient for prior to getting into the truck and trying to haul to the hospital.
Paul, is there a particular patient care scenario where you see providers taking that patient to the truck and beginning care versus starting care at the patient's bedside?
Yeah, there's a lot of them, pretty much every patient care type. But we see it most often in patients where either the provider didn't think the patient's clinical condition was very serious, and therefore they had time to scoot them out, and then the patient actually had a more serious condition than the providers anticipated. Or the reverse is true, where they see a critically ill patient, they say, oh my God, this is bad, let's get moving to the hospital so we're not wasting time on scene, and so they extricate at the expense of patient care. So one of the case that happened here locally a number of years ago was a patient who was in bad failure. It was a third floor carry down, a stair chair carry down, and the patient was in significant failure. And instead of throwing the patient on CPAP, which we all know works really, really well in most shortness of breath patients. In fact, by the time you get to the hospital, oftentimes these patients are able to talk to you and converse with you and have markedly less shortness of breath. But in this case, the providers elected to throw the patient on oxygen, throw him in a stair chair, and during the extrication, the patient desaturated and eventually went into cardiac arrest before they could get to the truck. Right. By the time they got to the patient into the truck and started resuscitating the patient, they couldn't get the patient back. Patient ended up dying, resulted in a lawsuit, and there was all sorts of problems with that. So, the thought I think that we're seeing collectively is that most medical directors or protocols want you to start treating that patient to reverse the condition for which you're there to treat the patient for. So in the case of shortness of breath, oxygen is not really a treatment. It helps to alleviate the symptoms of shortness of breath, but it doesn't reverse bronchospasm. It doesn't reverse CHF. It doesn't actually, really significantly treat the patient. So O2 may not be enough, right? A patient may continue to worsen with oxygen on because it doesn't have many properties that reverse the conditions, whereas bronchodilators do. CPAP certainly can help as well if a patient progresses to CPAP or it's CHF or whatnot. So, the answer was CPAP to move them out. Another example of that, Kevin, is patients with chest pain. So the providers show up, patients having a bad chest pain, pale, diaphoretic, clutching their chest. They throw them on the monitor, they see ST elevations, and they say, all right, time is muscle. Let's throw them in the truck and we'll do everything on the way to the hospital. That's actually the wrong answer in most jurisdictions by protocol. Again, if you're there to start treating that patient's condition, you really want to get the aspirin and nitro on board. So everything in your protocol up to that first aspirin and nitro is probably what you should be doing, including that aspirin nitro, before you make a determination to extricate them out to the truck. So there are quite a few examples where staying and starting treatment is key.
Right. We're starting our IV. We're giving first rounds, maybe first, second, third rounds of medication. We put the patient on the monitor. We do a 12 lead, and we get that patient set up for movement to the ambulance.
Right.
But that's what we are supposed to be doing now, as opposed to what we did in the late 80s, early 90s, where it was maybe get the IV in, but our thought process was always moving that patient out the door and getting that patient into the ambulance and transporting that patient to the hospital. And there's been an entire seat change with this, especially with cardiac arrest, right?
That's correct. Cardiac arrest, you're now sitting on scene for anywhere from 20 to 30 minutes, depending on your protocol, and working the patient there as opposed to trying to move them. And again, we know that during the extrication, bad things happen, right? So in a cardiac arrest situation, it's very difficult to maintain good compressions and to respond if that patient goes into VFib, for example, which is a survivable rhythm, as opposed to most asystole patients. And so if you can't act on those because you're in the middle of a third floor carry down again, then that patient likely doesn't do well. We also have a hard time doing good compressions in the back of a moving ambulance. So, and anybody who's ever tried doing CPR compressions in the back of an ambulance when you're bouncing around, you're trying to maintain your balance. And so as the vehicle shifts, your weight shifts, you come off the chest.
Right.
So we know we can't do good CPR during extrication and transport. So those policies have evolved. The same is true. Another thing, when we talk to providers and we discuss this with them, I bring up an example when I'm talking to them about the importance of treating on scene. And let's take your chest pain patient again. So this person's anxious. They're having chest pain. They think they're having the big bad one. They're wondering whether they're going to die from this. Their anxiety level's through the roof. So you show up on scene and you say, we're going to get him to the hospital because he's going to get to a STEMI facility, toot sweet, quickly. So let's throw him in the back, into a stair chair and carry him down. Well, what happens when you throw somebody into a stair chair and you strap them in so they can't move, and then you carry them down 2 or 3 flights of stairs? You're increasing that patient's anxiety. That is a very anxiety provoking procedure to do. Right. So if you have somebody who's potentially having a cardiac event or an outright STEMI, the treatment should not be jack up their heart rate, their pulse rate, and dump more catecholamines into their bloodstream from the adrenaline that you're producing from that carry down. That will worsen their condition. Instead, you want to give them that aspirin and nitro on the scene, talk to them, calm them down, use some coaching techniques to make them less anxious, describe what's going to happen, reassure them that even though they're strapped in and they can't necessarily move their arms and hands, you don't want them reaching out and grabbing things, that you have it under control completely. Make sure that you have enough providers so that you're not jostling the patient as much as you potentially might be without them, and do everything you can to reduce that anxiety effect that you might have on that patient. Same is true for shortness of breath patients, right? What's the last thing you want to do for someone who's significantly short of breath? Put them in a stair chair and carry them. And, a lot of, back in, and I don't know if they do this anymore in schools, but back in the old days, they used to put you in stair chairs or put you on a backboard and make you carry your peers around the classroom so that you could get a sense of what it feels like to be strapped to a longboard and have that loss of control. And even in that situation, when you were healthy and there was nothing medically wrong with you, your pulse rate went up a little bit. You got a little bit anxious from that. So stop doing that. Stop doing procedures to the patient, in particular the extrication, that can worsen their condition outright. If not, just their condition will worsen on its own because you haven't treated them, because you elected to move them out to the truck first.
Paul, is treating trauma different? Say a gunshot wound on the third floor of a three-family.
Yeah, trauma is, we all know the golden rule, right, for trauma and the critical first 10 minutes, right? So that's one of the situations where scoop and screw is probably your best option. Do everything en route. There are some, like every other policy, every other rule, there's always an exemption to that rule somewhere, and trauma is one of those. So if you have a condition, another is perhaps a critical, unstable patient airway that you can't stabilize. That may be another scenario where you want to minimize on-scene times. So there are a few select cases. Scene safety, right, is an obvious one that we don't talk about a lot, right? So if you got a pit bull that's at your throat while you're trying to treat the patient, and you can't lock up the pit bull, then get the hell out of the house, that sort of thing. But be careful you're not making up excuses. So, some folks will say, there's a big emphasis right now on stroke patients, right? That we got to get them to the facility to minimize their stroke. And so we should minimize scene times. There's a difference between minimizing your scene time versus scoop and screw and not doing any treatments on scene, right? There's a big difference. Trauma patients, you scoop them, you go, and you do everything en route. For stroke or STEMI patients, you probably should be doing your first 10 to 15 minutes of patient care. Get those first meds, get the IV in place so that they're, if the patient deteriorates, you're able to act on it quickly. But minimize the amount of time that you do that stuff and be cognizant of the fact that time is muscle or time is brain. And so that you still want to get moving, but not at the expense of not doing anything.
Right. And once we get them into the ambulance, how do we transport them?
Well, again, there's been a lot of literature over the year, but going back to the early 90s, there were articles about using lights and sirens in a judicious fashion. And perhaps we shouldn't be using lights and sirens to go to the hospital. And those articles keep resurfacing, and they have been for decades. And
a lot of research, too.
Yeah, a lot of research, too. Yeah, lights and sirens can be dangerous.
Yeah.
So not only for you and the patient, but for bystanders, right? There's all sorts of things that can happen. So because in most cases, the providers of today have the knowledge, skills, and ability to do everything for that patient that patient is probably getting in the ER for the first early 15, 20 minutes, maybe half an hour, depending on the patient condition, there is less of a need to race lights and sirens, hell on wheels, just get there, we got to get them there type of stuff. So take your time, drive carefully and cautiously. Don't be afraid to use a little bit less muscle on the gas pedal. Take your time going to the hospital so that the provider in the back can actually do their job and treat the patient, as well as reducing risk to everybody involved.
Yeah, lay off the brake, too.
Lay off the brake,
Lay off the brake, because we all know, we've all been in those situations. They put that netting now at the end of the bench seat for a particular reason. They put the seat belts in there, too, for a particular reason, so we don't slide around. We don't injure ourselves. We don't create additional risk for the patient. But, my advice, the second time around being in an ambulance after 20 years or so after being in my first one, was stay off the brake, stay off the gas pedal, glide, slide, turn the lights and sirens off. We don't need them going to the hospital. Lights and sirens and speed increase anxiety. It increases anxiety for the driver, increases anxiety for the tech in the back, and certainly increases anxiety for the patient. And with all the skills that we have, I mean, we have the drug box, we have the 12 lead, we have electricity, we have airway management. We got enough gauze to stop any bleeding. There is no need to hurry that patient to the hospital and increase their catecholamines, and probably, if it's a heart or a stroke, increasing the chemicals that increase demise of the heart muscle and the brain.
Right. And there are a lot of places now where they're enacting policies about, once you're headed to the hospital, you can do it without lights and sirens. If your service is not there yet and that's not in protocol, you can still drive a heck of a lot slower than people are typically driving nowadays. So yeah. I hear it all the time, again, when discussing cases with providers, and we talk about calls and say, hey, how come you didn't get a chance to do a 12 lead? And say, to be honest, I was hanging on for dear life. I kept telling my partner to slow down. They wouldn't slow down. They're swerving around cars. I'm falling over we dumped the drug box into the wheel well of the ambulance, and the drugs ended up everywhere. How do you expect me to do a 12 lead when I can't even stand up straight and I'm worried for my life?
Right.
So no good happens from speed. No good happens from racing to the hospital. It is just a high-risk endeavor that should be avoided unless absolutely essential. And there are very few cases. Even that trauma patient that you're scooping and screwing to the hospital with, because you want to limit your on-scene times, you still should not be driving 95 in a 35-mile-an-hour school zone. So you got to take it easy, lay off the gas. Patients will get better care if the practitioner in the back of that truck can treat that patient properly, because they're not being jostled around, and everybody wants to go home safe at night at the end of this thing.
Are we seeing our providers with the data mocking whether or not they're using lights and sirens? Is that part of the NIMS data set?
It is on the back end. That is one of the fields in the back, how you responded, but that doesn't generally end up on the front end run report for a lot of the printed version. It does in some cases. It'll show up on the run report. I have less concern of whether they're using lights and sirens unless it's policy specific. They should or shouldn't use them. It's not something that we talk about. It's more geared towards, in general, we're able to treat the patient properly based on the way you responded to the hospital, you transported to the hospital. And that's where a lot of the providers will say, no, but that's not on me, that's on my partner. I kept telling them to slow down, and they wouldn't slow down, type of thing. So the risk is huge. The liability is just huge to do that. So people have to get over the whole, and the problem is that once you trigger lights and sirens, it gives a little bit of a bolus to you, right, as the provider.
Well, right. Yeah.
It makes you feel like you should be rushing, but you really don't need to. So slow it down, be safe, take better care of patients.
So bring your equipment to the patient, treat the patient at the patient's bedside if you can. If you have trauma or some other type of high acuity that you really have to rush, you got to do that. But bring your equipment in, treat the patient at the patient's bedside, go fast but slow, be efficient, conduct yourself in a way that embodies confidence with the people that are watching what you're doing. And sometimes when we start getting excited and getting rushed, we look to the outside that we don't know what we're doing. So slow down, treat that patient, extricate the patient slowly, drive to the hospital, drive to that overcrowded ER slowly, and transition that patient care.
Yeah. I want to give you an example. Back when I was a new medic, when I got my medic in 1986, I've been a medic for about 6 months, and I was working with a more experienced paramedic who had 2 years under his belt. And back then, our protocol for chest pain patients was an IV and nitro. We weren't carrying aspirin. We weren't doing 12 leads at that point. So it wasn't similar. And you had nitro and morphine. And in order to give either of those and to start the IV, you had to get medical control permission. So I couldn't even start an IV without medical control. So
I remember
we
those
went
days.
to, and it seems so long ago now. But I remember this call. We were in a house. It was in an attic of a house, and the guy was living in the attic, and he was hugely obese to the point where he was going to be a carry down. And when we walked up to him, he was pale and diaphoretic, very anxious, sitting on the edge of his bed. And my partner got down on his knees, looked him in the eye, and started talking to him really, really calmly, really slowly. And I was a little bit amped up, realizing that this was probably a cardiac event and probably an MI. And so my partner said, "Hey, Paul, go downstairs, get on the phone." We at the time, we carried APGARs, right? Those Squad 51 telecommunications devices, right? Pick up the phone.
Yep.
And in order for those to work, because they only had a little antenna on them, you had to kind of be near a window and stuff. So you'd hang it out the window trying to contact. If that didn't work, you had to go downstairs, plug it into the box of the ambulance where we had a big antenna so that you had better range so that you get medical control. Yeah. So in this case, the APGAR wasn't working, and so I had to go downstairs to get medical control. So my partner says, "I'm going to give this guy nitro and morphine. Get me orders for that." Now, again, back in the day, we would do stuff, and then you got to get the orders, and that wasn't legit. We were supposed to follow protocol before giving these things, but you know, some people were loosey-goosey with that stuff. So my partner said, "Hey, this is my intention. This is what I want to do. You go down there and get those orders. I need those orders." So I went downstairs, hooked up the radio, talked to medical control, got orders for all that stuff, came back upstairs. And when I got back upstairs, the patient was no longer pale and diaphoretic. They were really calm. And when I left, he had ST elevations on lead 2 on the monitor. When I arrived, he had no elevations. And the patient looked like he was no longer having an MI. And I said to my partner, you gave him the nitro and morphine? And he said, nope, we've just been talking. I started the IV with the anticipation that you were going to get me that order. And his effect was so calming on the patient that I believe to this day that he talked that guy out of his heart attack. He just reduced his anxiety to the point where a lot of that symptomology went away. And I believe strongly that your effect with the patient helps determine their outcome. Act like you know what you're doing. Act like you've done this before. You're the pro. And if you're anxious, the patient's anxious. And anxiety is not good for patient clinical care. So reduce their anxiety, relax, take it easy, do what you were trained to do. You've got the ability. You can do it. You can take good care of these people, make them feel that way, as opposed to let's get them out to the truck and get them to the hospital, which implies you don't know what you're doing, and we got to get them to the hospital or something bad's going to happen. Yeah. So don't leave the patient with that impression.
I think that's great advice. Anything else, Paul? Any other cases that come to mind?
Not another case at the moment, but I do want to talk about bring your equipment to the patient's side, because oftentimes the providers will do the rapid extrication precisely because they didn't bring their equipment in. And the excuse that we hear from providers is, hey, I didn't have my fill in the blank, right? My monitor, my ambu bag, my IV equipment, whatever, because we didn't bring anything in but our clipboard. So we didn't bring anything into the patient's side, or we brought the wrong, I just brought my first in bag, but not my monitor. I didn't bring the O2. So now you're at the patient's side, the patient looks sick, and your decision-making tree is send somebody out to the truck, grab the stuff, bring it back up, unpackage it, and start treating the patient, or we've already brought the stair chair in with us because that's the only thing we did bring in with us. Throw them on the stair chair, get them out to the truck, and we can be out to the truck where I've got everything I need. And so they end up making that decision to take the patient out based on them not bringing the right equipment into the patient. So you want to make sure you bring all your appropriate patient care equipment into the patient's side. The next question that comes up from providers is, well, I've got 6,000 kits in the back of my truck. I can't bring everything. So what happens if I don't bring everything and I get there and determine that, I don't have something that I need? And there's actually a couple of different answers to that. The first answer is the expectation is that you bring your equipment to the patient's side, and the answer to what equipment is dependent on what the call gets dispatched as. So if you get dispatched to a particular type of call, you bring in your equipment with the expectation that that's the equipment you're going to need. If you happen to get in and find out that that's not what you're dealing with, it wasn't that you didn't bring the equipment or the right equipment in. It's that was an unknowable variable for you. And then you make decisions based off of that. In most cases, you probably still want to send your partner out to the truck and bring the equipment back in as opposed to doing the extrication, because the extrication, when you package them properly and extricate, probably takes longer than running out to the truck and grabbing an ambu bag. Right. Or something. So, and again, I'll give you an example that I use quite often when talking with providers. A number of years back, I had this call where call got dispatched as a child, a kid not breathing, a child not breathing. So we arrived, brought all our PD equipment in, got into the house, and it turned out to be like a 50-year-old guy who lives in mom's basement, and mom still refers to Sonny as her kid. So when she called in a panic, she said, my kid's not breathing. So the dispatcher took that to be a PD call. We took that to be a PD call. We brought our PD equipment in. We showed up. The patient coded in front of us, and we didn't have an adult bag. So we had to run out to the truck and get adult equipment. That's not on us. That's on, and it's not even on dispatch, unless you could say that perhaps dispatch should have said something like, well, how old is your child? Which would be helpful information. So perhaps it's on dispatch, but if you, in good faith, bring in the equipment that you need based on the type of call you think it is, and it turns out to be the wrong stuff, that's different from I didn't bring any equipment into the patient's side at all. And again, the answer is you probably should have somebody run out and grab that equipment as opposed to trying to do a rapid extrication. Again, that rapidity of the extrication is bad for the patient as opposed to a more laid-back, relaxed extrication that can be done if the patient's properly treated beforehand.
Paul, how about walking the patient to the ambulance? Are we still seeing some of that?
All the time. Yeah, it's a common occurrence. It really shouldn't happen for the most part. Now, again, there are some cases where the patient walking to the ambulance is legitimate. So, for example, you pull up to the patient's house, and the patient opens up the front door, they come down the 2 steps to their porch, and they're running across the lawn to the ambulance, right? So you're not going to stop them in the lawn and say, sit down on the lawn and I'm going to bring my equipment to you. You're probably going to allow that to finish out and then treat. On the other hand, if that same patient is coming out to you and they're gushing blood all over the place, maybe you should stop them and do something right there and not let them continue the extra 15, 20 feet. So it's really case dependent. But you really want to explain well in your narrative, in your documentation, how what the scene looked like when you showed up. Again, a lot of times the providers will say to me, well, he was right at the front door of the house. It was quick to just scoot him out to the truck. So the treat on scene thing doesn't apply because the truck was so close and it was right there. You really have to make sure that you can justify this properly. In most cases, the patient shouldn't be walking. In most cases, the patient shouldn't be allowed to continue to walk if they've started to walk. If the patient's coming down a flight of stairs down to the living room, that doesn't mean you open the front door and walk them out all the way out to the stretcher. You don't let them continue. You should probably stop them on the staircase, at the edge of the staircase, or right there at the doorway. Make sure there's nothing life-threatening that could be going on first. Start your treatments if necessary. If they're short of breath or something like that, get that neb going, right? That doesn't take a whole lot of time or effort. So again, minimize that patient walking thing. What we do advise providers to do is sometimes patients are insistent, and you should treat that like you would any other refusal of against medical advice. You should tell the patient that it's against advice for them to walk out to the ambulance. Here are the things that could go wrong if they walk out. It could exacerbate your problem. It could worsen your condition. Your shortness of breath could get worse. Your chest pain might get worse. We strongly advise you to have a seat. And if the patient says, nope, I'm not going to the hospital. I was in a stair chair once before, didn't like it, will not allow you to do it. You want to make sure you document that you made best effort to get them not to walk, and that you advise them of the risks of walking, and the patient was insistent, and you felt that in the patient's best interest, it was better for them to walk and you take them to the hospital and treat them at that point versus them refusing ambulance transport at all because you're not doing things their way. So you may get stuck in some cases where you have to do some of that stuff, but you definitely want to make sure that you document the circumstances very well as to what transpired that made you decide to allow them to walk.
I think it's great advice. If there is some type of anomaly in that patient care scenario, you got to document it, and that may mean in addendum to your original documentation, but document thoroughly what that patient said, what that patient wanted, your efforts in trying to convince the patient that this is not the safest way, and document that thoroughly. I think that's great advice. Mm-hmm. So anything else? Any other hot topic on treating patients at their bedside? Maybe covered it.
I think we've covered, pretty much all the essential stuff, at least the stuff we wanted to talk about today.
Yeah. All right. Well, everyone, thanks so much for listening. We hope you picked up a thing or two on beginning treatment at the patient's bedside, how it benefits the patient, how it reduces risk to the provider, and ultimately the EMS agency. Again, check us out at GerardSoch.com. For Paul Gerard, I am Kevin Kelly. Stay safe, stay in the fight, and Godspeed.
Goodbye, everybody.
Take care.
On fire.